something to not only protect the myocardium, but get better perfusion to those kidneys, acute kidney, they changed the name. You know, it used to be acute renal disease. Now it's acute kidney disease. Or it's acute kidney injury. I mean, it's like, let's change the name 5 times on something. Acute renal disease, acute kidney injury. If we don't do something, this can become... Everybody see that? What happens to patients with chronic kidney disease? So this man who thinks, I just had a heart attack, now, do you see the impact of multi-system involvement? So we want to help turn this around, right? And obviously, you're going to learn how to do that. Now, I mentioned chapter 71. Okay, don't worry about 70. I'll guide you. I'll pull it in for 70. Okay. There are reasons for acute kidney injury. I just gave you the biggie. Okay, which is referred to as pre-renal. Okay, we are now talking about causes. This is the big one, is right here. Okay, and this is only going to get worse as long as heart disease remains the #1 killer in this country. I showed you the stats last week about the obesity issue in our children. It's just going to get worse. Okay, pre-renal. We're looking at the causes of acute kidney injury. Okay. Another cause is often due to bacteria, infection, staph, strep, whatever you want to call it. That is referred to as intrarenal. This includes like your glomerular, which I probably won't spell it right, guys. Glomerular nephritis, genetic problems such as polycystic disease. Okay. You can also see, again, nephrotic syndrome. All of these are usually some type of infectious process. This one's usually genetic. Okay, it runs in the family, where the kidneys are actually, it looks like little cysts on them. There's a picture in chapter 70 of that, okay? So, intrarenal, okay? Another cause is called post-renal. This is going to be your obstructions. This is where all that stuff you learned about stones, that lead to, did y'all learn all about that? Stones is a big one, okay. So that obstruction only causes the urine, right, back up. So instead of having a simple case of cystitis, we now have polynephritis, which can destroy your kidney. Okay? Acute kidney injury. Acute renal disease. Okay? So, causes, prerenal, interrenal, postrenal, all of them can lead to decreased perfusion to the kidney. Okay? That is why when I have a patient that comes in through the emergency department, you know, they want to tell me about, well, we gave this, we did this, we did this. All I want to know is what is referred to as downtime. How long did my patient go without adequate perfusion? That's all I want to know. Because when they come up to me, you know, I'm like, well, do I have a brain that functions? But above all, do I have kidneys that function? A lot of times, no, I don't. And I'm going to work to turn this acute kidney injury back to kidneys that can function. Because let me tell you something. You take for granted going to the bathroom and drinking all your little fluids. Because you get a patient who cannot eliminate fluids. What happens when fluids back up? You're in trouble. You are in trouble. Do you realize you can drown in your own fluid? Okay, it's called pulmonary edema, and I'm going to slap you on a ventilator so fast it's not even going to be funny, because I can't afford to not have oxygen to your organs. They've already took a hit. So, it's a problem. When you give, I give Lasix drips. And I'm sitting there shaking this Foley, going, come on, come on, come on. I can guarantee there's no kicks in my Foley. I am holding it up. Hold it. Come on. Come on. Come on. Anything. Because I'm like, come on, help me. And I'm continuously doing that, and I'm adjusting this and doing this because I've got to have this. And like I said last week, guys, I don't care about your feet anymore. I will do whatever I have to do to support your vital organs, no matter what. Okay? So, causes of acute kidney injury. Does everybody understand this? Because I don't want you to say then when you go back, and because when this happens, these patients are one hot mess. And I'm talking hot mess. Okay? The most common form of shock is what? Hypovolemic. And that goes back to what your mama always said. You can, guess what? You can go days without food. But you can only go hours without fluid. Your body will not tolerate it. Okay? So, okay, these are some of the big key principles. So what I'm going to do now is I'm going to show you what's on the slides, which you guys, I know you got that one. It's got the toilet, right? Before, we'll break after that, because then we're going to hit it hard with the big nursing implications. Okay? So, let's look at what's on your slides. Say you're level 60. Urea's increased. Why is urea increased? Well, because protein intake, which, if you go back to basic fluid and electrolytes, and you look at the difference in the pressures, and I'm talking of the vasculature, intracellular fluid, extracellular fluid, it can change, right? You can be dehydrated and this level will increase. Okay, so there's some different factors you have to look at with a rise in a BUN. You should now see how cardiac output, perfusion, and just FYI, those two little peanuts, they want 20 to 25%, up to 30% of your perfusion because of everything they do. Now, they'll take a hit, okay? The functioning unit of the kidney is a nephron, and you have billions and billions of them, okay? And in fact, until you get down to about a quarter function, that's when you're in end-stage renal disease, okay? And in fact, you won't even really see this rise until probably 50% of the nephrons are no longer working. The kidneys will take a hit, just like the liver. But when they take a hit, it's bad news, okay? So, electrolytes. Everybody learned about sodium, potassium pump. Now you know about vitamin D, calcium. Calcium low, what goes up? Phosphorus. Okay, so we got a little bit in private. Now, what's in the extracellular? Intracellular. Got your values down to a science? You better. For boards. Okay. Why? Oh, nature dysrhythmias. Do you realize, I know a lot of you learned when that K is too low, do you know what's going to happen? You're going to start showing those frequent little PVCs. And then you're going to be in V-tach. And when your K is really high, your QRS is going to widen, guys, and your T waves are going to spike, and you can die from both. So you got chronic kidney injury. So not only am I worried about perfusion, well, you can't pee, and your dang K is 6. Like I said, we got a hot mess here. Right? One hot mess. And you wonder why I'm sitting there at the Foley going... Because my patient can die from electrolyte imbalance. not to mention all those dysrhythmias, that workload is going to rise. Okay? So, major problems. Well, your pH is 720 and your bicarb is 16, and because you're breathing so fast, I got to put you on a ventilator or a BiPAP or something just to keep your oxygen where it needs to be. One hot mess. Again, you should know normal plays a huge part in acid-base balance. Remember, the respiratory system kicks in first. The respiratory system is quick, but this is the baby that's going to try and make it all better with metabolic issues, and it takes them time. So you think it's like this when your bicarb 16 and it's just going to fix itself in the hour? Oh, no. I am working my fanny off just to preserve your organs. Okay? Yes, I run bicarb drips, but it isn't going to fix itself like this. And I can't afford for your oxygen to decrease, so now you can see why you're on the ventilator. Because I can't handle it, okay? You can't handle it. Urine is acidic, pH less than 7. Okay? I just went over that. Vascular tone. You remember way back when I said a lot of your patients are clogged from head to toe? You know what's the number one reason that pre-renal is the biggest? Diabetes, hypertension. Now, and you guys know, you've been in the hospital, a lot of you more than I have, and it's ridiculous. Everybody's diabetic, everybody's hypertensive. And they're going to lose their kidneys if they're not taken care of. So, and that affects vascular tone, okay? When you're already tight, you know, what's going to happen when you lose renal function? You know, I'm trying to tighten you down and at least keep a Doppler pulse. But my stars, you come to me and you don't have hardly any pulses to begin with. You're one hot mess. And I hate to say it, but I don't care about your feet anymore. I am trying to save your life, your brain, your heart, your kidneys. Another organ we don't give much attention, and that's the gut. And that's how you end up with a dead bowel. Or how I can't get you turned around no matter what we seem to do. And now you're distended, you got an ileus, I've slapped an NG tube down you. You're one hot mess. Do you know that? You know that. Clearance. Creatinine. Okay, creatinine is a byproduct of skeletal muscle breakdown. Therefore, it is more constant value than the BUN. The creatinine is your best indicator to determine if this is a renal issue. Okay? So if your patient has a creatinine of 2.5 and this patient needs to go for a cardiac cath, are you concerned and why?
Yeah, because the kidneys are not working out, we won't be able to excrete.
Okay, you know that we need to see what your heart's doing. But we're going to give you this toxic stuff called dye, which, by the way, your kidneys are already hurting. So you're going to give them a cath, and then you're going to come out to me, and your kidneys aren't going to work? One hot mess. Creatinine clearance. How well does your kidneys get rid of junk or waste? Urea, creatinine. Why do they need to do that? Can waste build up in your blood? Yeah, it can. And it's not pretty. As your kidneys fail, your ability, you'll think of it this way, to clear junk from the blood. So your ability to clear junk from the blood decreases, and therefore this will rise. Okay? As the kidneys fail, the junk is building up in your blood, and your ability to clear junk decreases. This is the Almighty to determine nephron function, glomerular filtration rate. So, if nephron function is adequate, this will be about 125 milliliters per minute. The ability to filter junk based on nephron function. Okay? When this drops to 10 milliliters, 15 milliliters per minute, do you think that's a problem? Yeah, you're buying dialysis or transplant, because that's going to be your only hope when the nephrons do not function at that point. So glomerular filtration rate, nephron function. Nephron, it's the basic unit of the kidneys. So, red blood cell production. So you've got a patient with chronic kidney disease. What do they look like as far as decreased erythropoiesis? Fatigue, pale, cool, because they stay in chronic anemia. Let me tell you. Chronic anemia. Oh, sorry guys. So, again, looking at the almighty CBC, the RBCs, the almighty hemoglobin. Vitamin D. I said this before. When vitamin D is not active, calcium does what? Decreases. Do you remember what happens when calcium decreases? Do what?
Stimulates PTH to release it.
And that's something. Yeah. Exactly. And when calcium drops, phosphorus rises. Well, that's chronic kidney disease. I can tell you what their electrolyte panel is going to look like without ever looking at it. And that's what I want for you. Because when you anticipate that, you know what outcomes need to be addressed, right? Because if calcium's too low, can you have dysrhythmias? Oh, yeah. You learned that last week. Very important to the myocardium. Okay? You can also think about other patients that would be affected by, could have a renal issue. Urge to void, usually about 250, 400. That can vary based on the patient. Residual urine in an adult, usually about 50 to 100. The problem with that is retention of urine, and urine's acidic, and urine sits there. What happens? Infection. Which, by the way, infection does what to your metabolic rate? Increases it. Which does what to the myocardium? Increases workload, increases oxygen demand, and that messes with my perfusion. Okay? So, this is going over some of looking at the causes of acute kidney injury. And I've added just a little bit more information for you. Most all that you should know. Okay? Meds. Why do we need to look at meds when someone has renal issues?
Yeah, clearance.
Oh, yeah. Oh, yeah. I've seen people not wake up for days because they're toxic on Ativan, or whatever else somebody's giving them. Okay? Also, you better think twice about giving these people electrolytes. You know, you can send somebody with a low potassium to a high potassium. Well, you know, as nurses, we don't really like to take you from one end of the spectrum to the other. Okay, we want balance. So you better think twice. Okay? So, very important, what used to be PP now has a whole new meaning to nurses. To look beyond the toilet. Okay? Eyes and O's are very important. All that is basic 111. You should already know that. Because now you got to think about something else that is application. Okay, most of you can anticipate that's basic 111. Diagnostics. There are many. Most of you know that work in the hospital. This is the easy one to obtain. Right? There are others that we can obtain. What is this? It is what?
Concentration.
Okay. The density of the urine to volume. Okay, to water. Density of urine to water should be 1.000. So the density of urine to water is now 1.038. That means you got something in your urine that's increasing density. Do you know that when the renal system fails completely, guys, does this work? No, it's a fixed value. It doesn't change at all. That's bad news. Okay? Bad news. You ate, shouldn't have a lot of stuff in it. Okay? patient has a biopsy, I can't tell you how vascular something is that demands up to 30% of your perfusion. So if your patient's had a renal biopsy, you better be watching for bleeding, okay? I mean, it makes sense when something is taking that much perfusion. Dye we've talked about. There's all types of tests, okay? Before we break, most patients, to put this in simple terms, do not like to talk about their PP issues. They don't want you looking down there. They don't want you messing down there. We don't usually sit around and talk about how often we've peed today. Okay? We don't like to talk about it if we have pain down there. So, you got to be creative. Okay? Most of these patients don't even want the physician down there. Okay? So, we'll take a break and go ahead and take a good fit. Remember, pre-renal, intrarenal, post-renal. Okay? A lot of your intrarenal come from infections, again, your acute glomerulonephritis, nephrotic syndrome, genetic issues such as polycystic disease, again, acute chronic diabetes. Hypertension is a big one with your pre-renal cause. Post-renal, your obstructions. Okay? As the nurse, you're constantly thinking about not just urine formation. You're thinking about waste clearance. What are my electrolytes doing? What are my bun and creatinines? And if you can get a GFR, what is my red blood cell, H&H? What is my calcium? What is my phosphorus? Are you making any pee? Okay. How do we do that? It's 0.5 milliliters per kg. So instead of 30 milliliters per hour, 0.5 milliliters per kg. Because I will take a drop, 2 drops, 3 drops. I'll take anything you've got. Not to mention, I'm assessing you and wondering, what is your metabolic system doing to the rest of your body? Because as your bicarb drops and your potassium rises and your hydrogen ion concentration rise, you're breathing faster and faster and faster. I don't like it. Because all of this is causing increased workload. So my oxygen is going drop, 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 drop. And we're in trouble. Your blood pressure. Your mean arterial pressure is dropping less than 60. We're in trouble. Okay? So, those are things you think about as you look at the different reasons for why the kidneys can fail. Some of this I have already mentioned. Okay. Azotemia, uremia. You got junk in your blood, okay? You got a lot of junk in your blood. How will you present? Well, when you've got waste products in your blood, you can get you're nauseous. doing this. You can be confused. Your breath stinks. Okay? And you're a hot mess. Because all of that stuff doesn't belong there. I mean, think about, guys, think about the lab values. 20 milligrams is like upper limit for bun. 1.2 is like upper limit for a creatinine level. So, again, you're talking about a hot mess. And again, it can make you confused and it can cause all other problems. I already mentioned your potassium is too high. You can die. You have metabolic acidosis. Well, the respiratory system is working as hard as it can, but what did I say? It takes the two little peanuts a while to try and fix volume, renin. Now, as the heart works harder and harder and harder, what happens to this? That mean starts to drop lower and lower and lower. So I got to not only control your rate, I got to get your mean pressure up. And not to mention, somehow I got to figure out how to get the fluid off of you before you drown in your own secretions. You're a hot mess. Now, to let you know, hopefully we can turn this around within the next several hours. Hopefully. Again, looking at GFR, it gives me a better indicator of nephron function. So when this drops lower and lower and lower and lower, your nephrons are shot. Well, that is not helping you at all. Okay? So, you know, for 30-some years, you thought not controlling your diabetes and taking your blood pressure medicine was going to be okay. Well, think again. Because now you're a hot mess. So, again, when you got junk in the blood, azotemia, uremia, you can actually see crystals, uremic frost, form on the skin. But, I'm like, the kidneys need to work, okay, please. Okay, again, you must understand, yes, pre-renal, interrenal, post-renal. Because you as a nurse have to anticipate what is the problem here. Why? You're a hot mess. A lot of you in the emergency department refer to it as a train wreck, which is probably not the best of terms, but oftentimes this is increasing your risk for death. Okay? When you lose renal function and multiple organs are failing, your chances of getting out of the unit are extremely extremely low. Okay, your risk to die is greater than 50% if we don't get this turned around. And even if you make it out, you're probably looking at dialysis for the rest of your life. So I can't emphasize how these people are a hot mess. Again, Decreased perfusion to the organs. That's all I care about. So if you waited, well, you're just making the situation worse. Okay? So you're in heart failure, and all you can think about is, I can't breathe, I can't breathe. Well, one reason you can't breathe is because you can't pee. Because the perfusion issue has now led to another organ being impaired. Okay? So, this is a problem. This goes back to basic 111. Okay, the kidneys are designed, the nephrons are designed to keep protein out. They're large molecules. But when the kidneys fail, the protein is no longer kept out. And when you lose that protein, where is the fluid going? Come on, guys. Larger molecules are higher pressure. So when the pressure drops, where is the fluid going? Say it.
The interstitial.
Yes. So you're blowing up like a giant balloon. But your organs are not getting the volume that they need because your kidneys are damaged, and now the large molecules that have the higher pressure no longer stay where they're supposed to stay, and the fluid is moving out. So you may be saying, well, give fluids. Well, I can sit there and give you fluids all day, and all I'm doing is creating a giant balloon. Because your intravascular is not getting the volume that it needs. Okay? So that is why this becomes another issue. Okay? To the point, it'll weep from your skin. It'll actually ooze out of your skin. So my giant balloon now, I have to wrap the extremities because it will ooze out of the skin. Because the fluid has nowhere to go. Okay? So you're a hot mess from all of these disturbances. Okay? So again, phosphorus rises, calcium drops. Vitamin D is no longer in an active form. Okay? Now, the next piece here, guys, is the phases. So we went over the causes and looking very briefly at our patient, and now we're looking at the phases. Okay. So obviously, initially, when you think about that patient I just described to you, you should probably be thinking they don't have any urine output. You're exactly right. And that is called the oliguric phase. Oliguric is less than 400 milliliters in 24 hours. Okay? Oliguric phase, less than 400 milliliters in 24 hours. Now notice, you're not going to stay that way. So as these progress, you will reach a phase called the diuretic phase. Now, you are excreting a large amount of volume, but it's not all urine. You can excrete 5 liters, even greater. But it's not all urine because the kidneys aren't there yet. They're not doing what they're supposed to be doing. So during this phase, I'm high risk for elevated potassium. This phase, I'm at risk for losing potassium. And as I said before, the kidneys can take a hit, but the point of all this, it takes them a while. To even know if you're going to have adequate renal function. If you're ever going to get back near normal. Never normal, but near normal. These are the ones that come in, and as a thinking nurse, I'm looking at the situation, and I'm looking at the history, all this mess, and I say to you, well, no, your baseline creatinine is 2.6. Well, that should spark brain function in my future nurse to think back to everything I said. Okay, because that's our baseline. Okay, that is our baseline. So it takes a lot of hard work to try and preserve those kidneys, but they will go through phases. Okay, as they try to slowly recover. Okay, so with that being said, I don't even know what's on the next slide since I got this up. Okay. All of this I went over. You're now thinking beyond urinary output and weight. Oh, you're thinking way beyond the implications. Okay? So, as you start to look at this patient, you're taking into all of the possibilities as to what is going on here. Okay? So obviously we're looking at our labs, we're getting diagnostics, and as a nurse, one of my critical outcomes become, do not add any more fluid to this patient. You know, I got dingbat coming in here going, well, just hang a liter of fluids in there. Are you kidding me? Or go ahead and follow the protocol for potassium replacement. Are you kidding me? That's all I can do to get it near normal. Are you kidding me? Go ahead and give them some Lasix. Susie, go ahead and give them. Let's hit them with 120 milligrams IV push. Sure. You know, I better be evaluating what this person's doing. Okay, so this bit of, let's look at this every 8 hours, every 4 hours, I'll take anything. Okay? As this patient is a hot mess, I cannot tell you their need for calories. Okay? Again, my protein values are dropping. One, obviously, when your heart's pumping fast, and you're breathing fast because of the metabolic acidosis, you're not eating. But two, because the kidneys no longer keep the larger molecules out. Okay? So, nutrition is critical. Fluid intake is critical. Salt intake. You know, you may not want to put up 0.9 normal saline at this time. So, there's huge implications for this patient. Outcomes. say we've tried Lasix IV push, we've tried a Lasix strip, we've done this more than once. My oxygen level keeps dropping, so I have to do things to my ventilator because fluid is going nowhere. We have actually short-term ways to hemofiltrate. It is called continuous renal replacement therapy. It came about many years ago. I was not a new nurse. Actually, I was quite an experienced nurse then. And this is a form of hemofiltration. Now, note, I said continuous. So, as the nurse, I'm taking off very, very small amounts of fluid and waste. Very small amounts. Okay? This patient is a 1-to-1 because it is all you can do. Okay? Just trying to take fluid and waste off and assessing and doing everything else to your patient. But it is continuous. Others are, continuous arterial venous hemofiltration. Of course, this is dialysis. Usually, if we have to go to dialysis with this very compromised patient, you better be watching their pressures and fluid volume status because hemodialysis is going to pull off more fluid and volume and, of course, electrolytes at a quicker pace, where I can run this for, say, 24 hours, where if dialysis comes in, they're going to run probably for 3 hours max, 3 to 4, depending on how the patient tolerates that. So I really have to watch my pressures when they're pulling that amount of fluid and electrolytes off, okay? There are patients that continue with dialysis for a short term because their kidneys, the docs feel they're going to recover. I feel like they're going to recover. And then others, no, you're going to be on dialysis for the rest of your life. Do you know dialysis is more expensive than a transplant? It costs this country billions and billions of dollars. Okay? So, you get to the point, it's, save the kidneys. Save the kidneys. If your potassium level remains high and your kidneys are not able to eliminate urine as it should, 0.5 milligrams per kg per hour, then I can actually treat you and try and move potassium back into the cell. This baby will do it. Okay, but because I am giving you insulin IV push, I am not going to bottom you out because I'm going to give you 50% sugar. This is the one that it's like infusing syrup. Okay, but you're going to do it very fast as a bolus. I'm going to give D50 and I'm going to give insulin IV push to try and move that potassium back into the cell so you don't keep having all of these dysrhythmias and increasing the dang workload, because that is not helping my perfusion issues. Okay? Another way to lower potassium is K-exolate. It's a thick stuff. It's nasty. You can give it via an enema. You can pour it down an NG tube. You've done that one before. But most is an enema. And what it's going to do is the potassium is going to bind in the stool. So you're going to duty-do. You're going to duty-do potassium out. Since your pee-pee is not coming out, we're going to cause you to have stools to bring that potassium levels down. Okay? Because your bicarb is not being absorbed, your hydrogen ion concentration is high, your potassium's high, your bicarb's now 16, your pH is 7.25. I can give bicarbonate as a push, and I also can run a bicarbonate drip to try and force bicarbonate to be absorbed to correct the pH. Okay? You can have dilutional. And potassium rises. What does sodium do? What? Goes down. Potassium rises, sodium goes down. Not to mention you have dilutional because you're a good year blimp. Hopefully these will work. Give you a whopping bolus of Lasix, put you on a drip. Hopefully. Unless that mean arterial pressure is less than 60. Okay, that's less than 60. I'm going to do something to this. Okay, to make it work harder without throwing you over the edge. So hopefully diuretics will work, and with these interventions here we can help get you back to where you need to be. Okay? So, if you have, what questions do you have as far as acute? None right now? I hope that's what you're saying. None right now. So, again, if the readings are, chapter 68 does not read well. But you can look at my slides. I think mine's a little bit clearer as far as basic renal function. But I have pulled material from 70 into 71. 71 is the one you need to really look at in regard to this content. Okay, it really helps look at the meat and potatoes of what you need to know. Okay. Hopefully, this acute phase will not go into this. So, you stay in fluid volume overload, right? Your blood pressure can be high or low. Your heart rate's too high. You're anemic. Your calcium's always low and your phosphorus is always high. And you live in a state of acidosis. Do you know a lot of these people die because of their cardiac status? Okay? Because the heart can't take it anymore. So, this is the patient you're dealing with. Again, it's going to increase in this country. You've got junk in your blood, too much junk. You don't feel good. You can't eat what you want to eat. Okay? So therefore you're at risk for infection because you don't have adequate protein. You don't have the folic acid, the iron, all that good stuff to keep you in where you'll heal. Okay? All of that is now compromised. Sorry. These patients can be what is called anuric. Anuric is less than 100 milliliters in 24 hours. Okay? They can be anuric or they don't, nothing. Okay, but it's inadequate, bottom line. It's 100 milliliters less than 24 hours is not going to cut it. What does this patient look like? Again, you got to think back to what's going on. All right? Junk in the blood. Your breath smells. You itch. You're nauseous. You can't think clearly. You're tired all the time. Can't eat what I want. You're acidotic. Which, by the way, acidosis will make this baby work hard. Your body doesn't like imbalances in pH. It doesn't like it at all. And it will work against it. I can't lose this. Okay, so you could actually die of dysrhythmias. You actually could die of fluid volume overload because you're going to drown. So we have a lot of issues here, okay, that we need to think about. So again, one of my key outcomes is don't add any more fluid volume to my patient, please. Okay? So don't be running IV fluids like a river. Keep an eye on those electrolytes. Know when you need to act. Potassium usually is never low. It hangs on the high side. Calcium, watch it. It's low. Watch your meds. Okay? Because now the excretion mode is gone out the door. This will mess up your skin when all your fluid is in the wrong place. Not to mention it affects your blood pressure. So your outcomes become this. You may never get to this, but these patients may have, with chronic, they're going to have to live with restrictions. Guys, if you have to go to dialysis 3 times a week and sit there for 4 hours, can you work? Do you feel like working? That becomes their life. Okay? They become very controlling. Do you guys get to go to dialysis? It's fun. You should go. They go early. They have their own little parking space. They want their own chair, and they want their nurse. And don't deviate from that. And if you happen to drive up, they're coming at you going, who are you? You're a new face. You're a new person. You're in my parking space. And the students will go, I'll move my car. I'll move it. And that becomes their life. Okay? It's all around that. Okay? Again, what can you do as a nurse? So I'm going to keep these up, okay, since I got them up. So nursing implications beyond the obvious, which could hurt your life, is, so you can't have fluids. You got to have some fluids. You can't survive. So small amounts, okay? Because edema, as you learned, can go anywhere. Abdominal cavity. Don't breathe well anyway, especially, the day before my dialysis. I don't feel good at all. So, sometimes on the weekend they want to have a little protein. Well, again, that can be very harmful to you. So they've got to watch protein intake. Watch things with potassium. You guys should know this from the first year. What has potassium in it? Salt substitute. You remember what? Very good. Okay, what are foods? You guys, you know that? All right. All right, I'm not going back to first year. Okay, a lot of these patients do have to take. Now you know why. A lot of vitamins, iron supplements. You can actually give erythropoietin sub-Q. It's called Epigen. Okay, oftentimes the dialysis nurses will do that. We also do it in the unit. Epigen is very expensive. It usually comes pre-filled because pharmacy's like, you're not wasting this stuff. We also can give iron. We give a lot of iron IV now. Very important to look at our meds. And in particular, I want you guys to think about those drugs that can be nephrotoxic. What are the big ones? NSAIDs. Which ones? Metformin. But what's a big class? There you go. A lot of your antibiotics can be nephrotoxic. Oftentimes pharmacy should be looking at that, and they look at a lot of other stuff, and adjusting the dose so this patient doesn't become toxic, and make sure that we as nurses are monitoring levels on certain ones. Very important to consult dietary because, as you can imagine, their diet is very limited. And this is very important. Very, very important. Again, now you guys should be able to figure this one out. Activity intolerance. Well, what is that related to? The continuous anemia that we see. How can you help this patient to not increase workload? Okay. So, things that you can do as a nurse, as well as monitoring this patient, monitoring lab values, making sure they're taking their vitamins and medicines as they're supposed to. A lot of patients do not like this because it does what? Constipates. And what do you need for absorption? Take it with vitamin C. That's basic 111. Your outcomes are listed for you. The list is endless as far as this patient is a hot mess. Okay, I'm not going over those. You guys should know that stuff. However, very, very important information. Okay? Again, these patients' lives revolve around their restrictions. Okay? And you can see high incidence of suicide in these patients. You can see them give up I'll skip dialysis today. I'll eat what I want. I don't care anymore. That is not uncommon. High incidence of depression. Okay, do we need a break? Yes, Kim.
Just a quick question. My father-in-law's in kidney failure, and he's on dialysis at home. But they have increased his protein. They want him to eat a lot of protein.
Well, if he's on dialysis, and he's compliant, he's not going to put himself in a, you see what I'm saying? In a more harmful situation.
So because he's in dialysis, it's okay.
And he's compliant.
But if he's not compliant, then we have issues.
Oh, yeah.
Is that compliant with the dialysis or compliant with the diet? Or both?
Both. Because you increase protein, which they need desperately.
Because they're in dialysis.
But if they don't, or they're not compliant, then they're just going to build up more waste for urea. So, yeah, very, very important. Okay, so let's look at meds, get on pharmacology, okay, before we take a break. Okay, a lot of these patients take bicarb. You can take bicarbonate in a pill form. You can take calcium. Okay. A lot of them, again, could be on diuretics, especially if they're like anuric, right? They produce 100 milliliters in less than 24 hours, but they could. Again, because of the increased volume, a lot of these patients could remain in a hypertensive state. Anemia, we can give iron, all of our vitamins, epigen. K is high, I can give K-oxalate. Okay. So, So, again, where does that lead us to? We want this patient to turn around. If they, and hopefully that's in the hospital, we've helped them turn around, but it could take up to a year. That depends on the patient and what they are seeing in the outpatient basis. My goal is simply get them out of the hospital or get them out of that acute state, that critical state. If this patient does develop chronic or this patient has polycystic disease and they've had it their whole life and they're actually quite young and they have chronic renal failure, then we are left with treatment measures that have to be done 3 times a week. Okay? So, okay, I'm pouring in content, so get up, and go take a break, okay, etc. And then we're moving to shock. Okay? Hemodialysis is, dialysis nurses are specialty. What is in the dialysate, which is what is the stuff that's going to pull off the fluid and electrolytes, is ordered by the physician. Okay, and that can vary depending on where the patient's at as far as disease process. As a nurse, you should note that they have a graft or shunt. It's called an arterial venous graft or shunt. please do not do blood pressures, IV sticks. You always assess for a thrill, and you auscultate a bruit. That tells you blood flow is present. If it is not present, you are to call the dialysis nurse immediately, because that can compromise the patient's care. So again, no blood pressures, no IV sticks. That patient cannot afford to have that shunt messed up. Assess for a thrill, okay, and auscultate a bruit. Do not give these patients medications prior to dialysis. Majority of meds are going to dialyze through. Do not give them their cardiac meds unless the physician says to. If you start lowering their pressure, that dialysis nurse is going to be very angry at you, because pulling off that fluid is going to cause fluid shifts and the pressure is going to drop. And that's going to increase workload just because of the fluid shifts that are occurring. So again, don't give meds is a good rule of thumb. You know, and I even question it. If a physician says, yeah, go ahead and give this, I call a dialysis nurse.
How much of a blood pressure drop would be like a concern for a patient who
Anything sustained less than a mean arterial pressure of 60. Okay? I mean, I can have a patient with a mean arterial pressure of 70. They start dialysis, and, you know, I go over here to wash my hands and turn around going, whoa. Because of most patients it is, unless they're in, like, the intensive care unit, where they're very compromised. But for most, yes, it's high. And they don't want you giving something to lower it. Yes. Yeah, they just try to maintain perfusion, obviously to the brain and the other organs, okay, as they're doing this. So it is a slow process, but it does have major restrictions for hemodialysis, okay? If short term is needed, you may be saying, well, or you may not. You may just be going, oh my God. But if you're in like the unit setting and the physicians, they decide on, let's try hemodialysis, maybe very slowly, adjusting the dialysate or whatever, and monitoring the patient. They can actually put an arterial venous access into your femoral subclavian vessels if needed. Those are short term. Okay, I went over this. Don't mess up the shunt. Okay, again, fluid shifts. Risks, obviously, for those two. Less and less nowadays, because we're better. These are just some pictures you can look at. You can see the arteriovenous access. You, as a nurse, take care of it. Okay, this now becomes the kidney right here. This baby is high risk for clots right here. So dialysis nurses are given heparin so that the dialyzer doesn't clot. Doesn't help the situation, but you got to have something to keep it from clotting. So that becomes the kidney doing the work. And of course, they're continuously monitored. There's inpatient dialysis at Northeast, isn't it? That would be a cool place to have. Huh? And Rowan. Okay. And of course, there's tons of outpatient that I'm sure you've seen. Right. Okay, emergencies. I have seen fluid shifts to cause. This baby doesn't like it. It doesn't like overload. It doesn't like changes in fluid, and it certainly doesn't like deficit. So these patients can become compromised. This would be if it was not treated, as I mentioned, or if the patient is non-compliant. Okay. Again, they can become very, very compromised. This you want to call immediately. This, again, heparin circulating to keep the dang dialyzer from clotting. So we've got a slew of issues. So again, dialysis is a specialty. What you need to know is a generalist, what the generalist needs to know. Okay? It is very restricting. They are very controlling patients. Okay? Their life revolves around their dialysis. Okay? This is another form of dialysis that some patients may be candidates for. Only some, not everybody. Okay? Why? Because this is a slower process, but it allows less restrictions. So if a patient is a candidate for this, it allows them actually a more normal type of lifestyle. In that, this can be done at home. Okay? The actual peritoneum now becomes where the exchange is occurring. Okay? So they have a catheter. It's called a Tinkoff catheter. Now, the most important thing as far as a generalist is that that baby doesn't get infected. Or you're going to end up with a nice whopping case of peritonitis and you're probably going to die. So the catheter for peritoneal dialysis is here, and the peritoneum becomes where the exchange occurs, or like the dialysis. Okay, again, it's slower. Some patients can even do this at night. They'll hook themselves up. They'll infuse their dialysate. It will sit and do the exchange. And then there's a bag that is down here to release all of that fluid and waste. Okay? So the beauty of this is less restrictions. It can be done at home. Again, it can be continuous. You can see it's going in and then it drains. And that, the amount of time and the solution for the all that's ordered by the physician. Depends on what is going on with that patient. Okay, so that becomes their options. Their only chance for a more normal life is another kidney. Okay? And, you know, we're actually pretty good with kidney transplants. There's not enough. I will tell you, a living donor, maybe a family member who has the right tissue, pathology, and all that stuff, you've got a greater chance of living a more normal life. It's no different, guys, than the heart. The greatest risk is, of course, rejection. They're on lots of meds, immunosuppressants, corticosteroids. They have to have their immune system monitored for those reasons, okay? But it can be an option for the patient. Rejection. And again, because the meds cause the immune system become compromised to try and prevent rejection, they have to be very, very careful. Okay, so hold on.
You want to flush the toilet.
Doing that, it does help you to prioritize, okay? So this is how my mind works. And when I read a chapter, I don't focus on every little intervention until I identify what the priority issue becomes. So based on our discussion from yesterday, when you have problems, and that can be what falls into that category. Okay, what falls into this category? Okay, what falls into that category? Okay, so based on the different causes, it helps me to look at this patient and identify with acute kidney injury. And again, I want it to be acute and not go into chronic. My goals, my outcomes become enhanced perfusion. Okay, that becomes critical because if I don't keep enough through the perfusion through the systemic bed, then heart rate will rise. That's going to alter, first of all, the almighty brain. And it's going to lead to excess fluid volume overload, which could further decrease my perfusion, decrease cardiac output, impair gas exchange, leading to the continuous compensatory response as the body tries to help itself, this only leading to increased systemic resistance, increased volume, therefore leading to decreased peripheral perfusion and impaired gas exchange. So what I'm doing, I'm taking your reading from 68 and 71 and putting it all in a nursing perspective. With a fluid imbalance, I want no extremes in electrolytes, no ups or downs with potassium, no ups or downs with sodium, and in particular with acute kidney injury, no decrease in calcium resulting in the increase in phosphorus. I also, based on the erythropoietin loss, I want no extremes in my hemoglobin, hematocrit, red blood cell production, thus leading to increased heart rate, therefore decreased cardiac output, electrolyte imbalance leading to dysrhythmias resulting in decreased cardiac output. Are you with me? That's how your mind must now work. With that foundation, with also knowing we're going to be anticipating different phases. Now, in particular, with the initial acute kidney injury, we're going to anticipate the oliguric, which results in urinary output of
Less than 400 for 24 hours.
Exactly. So therefore, I'm tying that information in, knowing that I've got a lot of work to do. Not to mention, and I didn't put this down here, my assessment values in terms of my renal baseline function. Also trying to identify nephron function as we continue to take care of this patient. So, if this is a cardiac issue, you should be pulling in all of your lab values. Know what? Am I talking about respiratory or metabolic? Metabolic, because how is that going to impact this? Exactly. It's going to increase that respiratory rate, which increases my demands. And it's just a hot mess. Okay? So, with this being, if it's a cardiac issue, let's say pre-renal, that is the most common, due to, of course, our history of diabetes, hypertension, we're going to protect the myocardium. We're going to help the myocardium. Okay, you guys have already been taught cardiac stuff. We're going to also address what can these kidneys really do. What might be something that physician might order? Diuretics. Before we progress to impaired gas exchange. Because bottom line is airway breathing circulation is a priority. Okay, so based on that, we are initiating those actions, hoping to enhance this and prevent this from occurring. Okay, now we also talked about electrolyte imbalances. Okay, let's say that I call the physician because that potassium level is now 6 as my urinary output continues to decrease. What might I expect the physician to then say? Okay, give D50 with IV push insulin. Let's try and pull that back into the cell. Now remember, that's after we've tried diuretic therapy, right? Because we want the kidneys to work. And that would be our first choice. Let's get those kidneys to work. Let's make them work. Well, you and I know now that a lot of that is going to depend on how long did they go without perfusion? What are these values? And how much nephron function do I have left? Hopefully in the acute situation, I have at least 50% left. And we can turn this around, okay, for this patient. With extremes, we don't want this. So how can we enhance this if they are not making enough erythropoietin? Okay, iron, folic acid. Remember I said yesterday you can give iron IV. We do that a lot.
Vitamin C, that's what iron.
Huh?
Vitamin C to absorb the iron.
Vitamin C to absorb the iron. So again, you don't want them to continue this downward progression to only 15-20% GFR. Because the lower this becomes, the harder it is to turn this situation back around. And if we have to, what might we do as a temporary action? Dialysis. Remember I said yesterday, you can do continuous renal replacement therapy. We can put in a temporary catheter, an arterial venous catheter. We can temporarily dialyze this person. If I'm not meeting my outcomes, but we still think there is that chance of turning these kidneys back around. But you and I know that the phases will occur and that this can be a very long process. It can take up to a year or more for these patients, all depending on how long did they go without perfusion and how quickly did they receive interventions. Okay, that is why when you've got somebody that's been without perfusion for 15-20 minutes, well, you're a hot mess coming in to the unit, trying to preserve and protect your vital organs. So you see now how the systems all come together to lead you to make the best selection in your actions. Okay? So if you can fully understand this, then you are getting a very good handle on renal function. In that, you're seeing the implications of perfusion, okay? The implications of volume overload, the implications of the body's compensatory mechanism to try and protect itself, the indication of how to protect the body from the more common extremes being the high potassium, sodium, calcium, and low calcium, high phosphorus. So those, this would be high, sorry, this one low. High potassium, low sodium, low calcium, high phosphorus are more common in this type of patient. Protecting their hemoglobin and hematocrit status to ensure that oxygen is being delivered to the vital tissues, organs. Monitoring that renal function. Okay, so by looking at all this, you are truly looking at the full effect of the kidneys. You also, though, cannot forget the impact on the brain, obviously, the impact on the respiratory system as it tries to help the situation by taking into account the metabolic acidotic state. Okay, so the systems come together. And the nurse must understand, even the generalist, understand how to prioritize these issues. Like I said, when you start looking at this, not a priority. It's not. It's not a priority. I hate to say it, but your gut isn't a priority. Yes, I want you to have a normal gut function. And as we move into what happens when it doesn't turn around, Miss Rummel, what is going to happen if they keep going down? Well, they're going to go into cardiogenic shock. And then that's going to lead to hypoperfusion to my vital organs. You're going to go into shock. So that is why you have to start looking at things in this manner. This is the nurse. This is the process. And this is how the process is applied. And it takes a lot of work and a lot of practice. And I know a lot of you are probably looking at me, and yes, that dang concept math is easy. Because this isn't. This picks your brain. And those of you who have been with me know, she picks your brain. So that is to help you to see. And now, as a new graduate, you're putting all of this together. And that's very, very important. Okay? So that is looking at basically acute kidney injury. What questions do you have in regards to this patient? I remember. Are you not awake yet? You understand? Can understand and apply acute kidney injury, they should be able to apply the information that is necessary for chronic renal disease. Okay? So this is a different patient situation, different outcomes. Okay? As they must live with renal failure, okay? What does your outcome become? Maintain. Maintain function of whatever's left of their organs, and I mean vital organs. So, maintain whatever perfusion we have left. Maintain whatever our volume status is. Maintain respiratory status, whatever is left. Because their extremes in lab values can definitely be present. Okay? Especially prior to dialysis, right? So we know that prior to dialysis, they could have a change in LOC. Why is that? All that junk in the blood, those nitrogen, those waste products in the blood. Remember, azotemia, uremia. So they can have that, and we expect that, okay? They can have what as far as cardiac issues? Okay, dysrhythmias due to electrolyte imbalance alone. Okay, not to mention what that excess volume is doing. And that's not just to my heart, that is to those lungs that we rely on for gas exchange. Okay, so we can anticipate abnormals in their ABGs, decreased oxygenation, metabolic acidosis, increased respiratory rate. You could even anticipate dysrhythmias, not to mention an S3 heart sound. What does that mean? Okay, congestive heart failure, fluid buildup. And we also have to anticipate that this person's potassium level is, okay. We also must anticipate that their bun, that their, is that right? Creatinine, I think. Okay. That their GFR, excellent. So their ability to clear stuff decreased. Okay. We can also anticipate that their hemoglobin is anemia. We also know that their calcium is. So what is that doing to their body? Right. Exactly. It's breaking down, pulling from the bone, and so therefore you're going to have fractures. And we also know that phosphorus is going to be high. So we can actually see this patient just by now looking at the diagnosis. And like I said, you have to see them. You know, how are they going to feel with all this junk in their blood? Nauseous, tired, itchy, confusion. How are they going to feel with their anemia? Tired, fatigued, don't want to do anything. Okay? Because their life revolves around basically this machine that works as my kidney. Okay? Now, this patient has access, and as a nurse, we will and why are we doing that?
To make sure
that it's patent. Okay? The thrill and the brewing. Okay, make sure of patencies. Avoid blood pressure, sticks. Don't mess with that thing. Okay, and don't mess it up. Okay? We also know that they have a list of meds this long. When are we going to get them? After. Okay. After dialysis.
Like after going into the day after dialysis, they're watching toxic use because it's not clear and they're going to say drugs. Like all the time.
And when they're not compliant, they end up in the unit. Because they're a hot mess. Depressed.
Their life is what it is.
Yes, a lot of depression. Okay. So, a ton of nursing implications. So, they come back and they're much more alert. I'm very happy with their lab values. Maybe not normal, but better. fact, I usually tell the student or my new nurses, at least we're back to baseline. We're back to where they should be, okay? And so now, you want food, because they can breathe better.
No high protein, low protein, high fat.
Low protein, low salt.
No potassium.
Very good. Limit that potassium as far as foods, salt substitutes. Limit, somebody said fluids. Space out your fluids throughout the day. Smaller meals. More frequently. Because yes, they need calories. Obviously. We discussed about their meds. We talked about how this would be lowered. Are we concerned with their values being this high?
Yeah.
Are you going to monitor for toxicities? Yes, with certain medication. It is extremely important. For the low calcium, what can we give them? Okay, calcium supplements. Supplements, I think that's right. Okay. Vitamin D. Can we give them bicarbonate? Yes, you can. That does come in pills, giant little pills. Okay. What about the high phosphorus? Okay. The Robin mentioned Tums, the antacids. They will bind with the phosphorus. Phosphate binding medications to keep that controlled or baseline. Okay. What about the low hemoglobin? Okay, you can give, run out of space, iron tablets with iron. You guys mentioned you need vitamin C. Right, stool softener. Okay, you guys know all that. Vitamins. We mentioned that yesterday. Vitamin supplements, especially with a low protein diet. How do I assess protein? Albumin. Okay, very good. Very good. So again, our outcomes are very different. Maintain, I'm trying to keep them at baseline is our goal. Okay, which a very different situation with this patient. And you guys, I mean, you've had psych, so I'm not just, we got only so much time here, so, that's why I'm not focusing on psychosocial, but you can already see the high incidence of depression, suicide with this type of patient, okay? Now, yesterday we did talk about one other type of dialysis that some patients can be candidates for. Okay, peritoneal. And you can see these patients out in the hospital. And what is the difference with that? Not as restrictive. Because where is the exchange occurring?
In the peritoneum.
Peritoneal cavity. Okay, so they have a catheter where they can access. Okay. Now, the big complication with this type of dialysis. That's the biggie. So if that catheter has any signs and symptoms of infection, the dialysate, the outflow, which is what's coming out of the patient, does no longer look clear, then that patient needs to seek help immediately, because peritonitis you can die from that. Okay, so, but an option for some of our patients to give them a more, normal life. So, little bit of difference in those two. But again, not all patients are a candidate for peritoneal. Most are dialysis. Okay? What questions do you have, in particular in regards to nursing implications?